is Mubarak al-Nasr, one of the medical oncologists at Princess Noor Oncology Center, King Abdulaziz Medical City in Jeddah, treat mainly lymphomas. Have my friend and colleague today, Dr. Hani Hashmi, who's going to introduce himself.
First of all, thank you for the organizing committee for the invitation, for Dr. Shadi and Dr. Shaheen. My name is Dr. Hashmi, Hani al-Hashmi. I'm actually from King Fahd Specialist Hospital in Dammam, in the Department of Medical Oncology, Hematology and Bone Marrow Transplant. Mainly over the past 2 years, I've been doing hematology purely and bone marrow transplantation. And it's actually a pleasure for us to be with you guys here today.
Okay, so as you can see in about the lymphoma module today, we have few lectures, and we'll start today with Dr. Bassem Beiruti. I think everyone knows Dr. Bassem. He is assistant professor at King Abdulaziz University City, and he is also a hematologist treating bone marrow transplant at King Faisal Specialist Hospital in Jeddah. He's a double certified American Canadian Board in internal medicine and hematology also. So welcome, Dr. Bassem. As was done yesterday, we're going to leave all the questions to the discussion part. So we'll go through all the lectures and we'll have time for discussion, inshallah.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيد الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه وسلم تسليما كثيرا وبعد. I would like to take this opportunity to thank the King Abdulaziz University Endowment, who initiated this idea of having a medical conference with no registration fee. This is unheard of, but there is a merit, there is a compassion here for spread of knowledge to staff without any fee. And I'm really thankful to Prof. Hassan Kauthar, because he insisted that this conference should be free. That's me, and I am King Abdulaziz University employee, working part-time in King Faisal, helping patients everywhere. I have no conflict of interest, and this where I was trained in Toronto. This is Princess Margaret Hospital, and Toronto General Hospital, and Mount Sinai Hospital. And here where I am now at King Abdulaziz University and King Faisal, where bone marrow transplant is happening. That's my love university. This is my department, and we have big department. We have 25 hematologists. Currently we have 8 consultants, and we have different divisions: adult, pediatric, transfusion, and hematopathology, and we have different activities. And that's our department vision, mission, and core values. And among important core values is the compassion. So compassion is above everything, before anything, and in everything. Our God is the most merciful, most compassionate. Our prophet is sent by God as a compassion to the whole world. وَمَا أَرْسَلْنَاكَ إِلَّا رَحْمَةً لِلْعَالَمِينَ. Our religion is the faith of compassion, and our Quran is full of compassion. Our relation is based on compassion. رُحَمَاءُ بَيْنَهُمْ. And the passion of medicine is compassion. Compassion is the word that should lead this world. This is BMT updates, or bone marrow transplant updates. Nowadays it's called hematopoietic stem cell transplantation. But from this concept of hematopoietic stem cell transplantation, it's now moving into stem cell transplantation or stem cell therapy, or mesenchymal cell, or undifferentiated cell, or induced pluripotent cell, and other names, stromal cells, because these are resources of many future medicine. In reality, bone marrow transplant for hematological malignancy, now the indications are decreasing. For example, chronic myeloid leukemia, in the last century, bone marrow transplant, allogeneic bone marrow transplant, was the standard of care. In 21st century, not anymore, there is molecular targeted therapy. However, stem cell therapy in regenerative medicine is the new and increasing more and more evidence, but still it's investigational. Actually, the American Society of Hematology, this last year, 2012, there were major sessions about stem cell therapy in regenerative medicine. And as you know, that the Nobel Prize winners for 2012 in medicine and physiology were two scientists who worked on induced pluripotent stem cell. In many universities across the world, East and West, stem cell institutes have been established. For example, Harvard Stem Cell Institute, University of California Stem Cell Institute, and soon with our leadership from our dean, Prof. Mahmoud Shaheen, and the university, we will have King Abdulaziz University Stem Cell Institute. In 1999, when I did my master in immunology, I thought that all the life is based on immunology. And I thought we need immunology for health, disease, and in therapy. And I looked at stem cell therapy as a way of changing immune reconstitution. So in health, we need the immune system, in reproduction, for fighting infection and inflammation. But if there is derangement of the immune system in immunity, it will lead to immune deficiency, and we treat immune deficiency by stem cell transplantation. In reproduction, if there is derangement in the immune system during pregnancy, we can have rarely rejection or graft versus host disease occurring between the mother and the baby. In infection, because of disturbed immune system, infection can lead to cancer through defective immune system, and that's clear by HIV story, where we have now patients with HIV, they are living longer period now due to the heart medication, but they are prone to more and more malignancies. In inflammation, when there is excess or disturbed immune regulation, we will have autoimmune diseases. That was 1999. But in 2012, where more evidence is apparent, we are living in a stem cell environment. Stem cell is the basis for health because every tissue in the body is originating from the stem cell. We have stem cell for the hematopoietic system, for the adipose tissue, for the cardiac tissue, for the gastrointestinal tissue. All these organs and tissues originate from stem cell. And reproduction is another fertilized ova that will lead to the human body, the baby. And stem cell infection will lead to stem cell cancer and inflammation, autoimmune diseases, although the amount of literature searching into this is a stem cell disorder, because we have exposure to many inflammation, but why certain people, they are getting the autoimmune diseases. And in disease, stem cell is baseline, diseases are stem cell based. The clear example now, cancer cancer is not anymore uncontrolled cell proliferation. No. Science now is talking about cancer stem cell. And if you want to be successful in treating cancer, you should try to identify this cancer stem cell, and target the cancer stem cell to get better yield. And that's what's happening in oncology. Molecular targeted therapy, monoclonal therapy, trying to identify the cancer stem cell and targeting it. Not only cancer, atherosclerosis. People think of atherosclerosis as hyperlipidemia, hypercholesterolemia leading to atherosclerosis. Not anymore. Science is saying atherosclerosis is a stem cell disorder. They identified atherosclerotic stem cell. They infused this atherosclerotic stem cell into mice. These mice developed hypercholesterolemia and atherosclerosis. Because we have evidence that people, they can have atherosclerosis without high cholesterol. People have high cholesterol, but they don't have atherosclerosis. And our therapy of atherosclerosis, it shouldn't be any more statin and Lipitor, etc. It should be stem cell targeted therapy. And that's why stem cell therapy is indicated not only for cancer, but for regenerative and stem cell and regenerative repair tissue cell. That's our evidence. And I'm among the first Saudi who got this clinician investigator program certificate. That's the mother. And that's her heart, but we'll have some poetry. I love poetry. قال ائتني بفؤاد أمك يا فتى ولك الجواهر والدراهم والدرر فمضى وأغرز خنجرا في صدرها والقلب أخرجه وعاد على الأثر لكنه من فرط سرعته هوى فتدحرج القلب المعفر إذ عثر ناداه قلب الأم وهو معفر ولدي حبيبي هل أصابك من ضرر. Stopped again. Oops. So this is how men think of women getting pregnant. I mean, they go to shopping mall, they get this baby, they put it in their tummy, and that's it. No. Pregnancy is science. And why I am, as a bone marrow transplanter, interested in this pregnancy science? Because in pregnancy, there is haploidentical. Half of the baby is from the mother, half of the baby is from the father, but there is no graft versus host disease. In my opinion, if we study pregnant women carefully, our transplant outcome will change dramatically. And that's the difference between implantation and transplantation. So implantation, it's physiological. You don't need HLA. We don't do HLA typing for the husband and wife. They get married. They have children. There is no GVHD. There is no immune suppression. But in transplantation, when there is unrelated or related transplant, we need to have HLA typing. We need to have matching. There is immune suppression after transplant, and there is treatment-related morbidity, mortality, all these complications. And that's a product of haploidentical implantation with no graft versus host disease. Okay. That's our kingdom. It's a big country. There is 13 administrative regions, and that are the current transplant centers in our kingdom. The first one established is in King Faisal Specialist Hospital, Riyadh, in 1980s. Then Military Hospital, then King Faisal, Jeddah, and then Suleiman Faqih, but they closed now, and then King Fahad in Dammam, and National Guard in Riyadh. And our university, we did the first transplant in October. Second one is undergoing, not yet engrafted, so I'll not talk about it. But we did our first transplant in October 2012. And soon, National Guard Jeddah, they will join the transplant centers. And that's our Makkah al-Mukarramah region. It is composed of 11 districts or sub-regions. And the population we are serving is 3.5 million. It's a huge area, and that's why we need more than one transplant center in the Western region. And that's the current situation of transplant centers in the Western region. The only real, I'm not talking about our institution in the university, it's a small starting, but the real transplant center is King Faisal Specialist Hospital Research Center, Jeddah branch. University, not yet. We cannot accept cases. It's single case. And we have 61 hematologists. The largest institution that has the largest number of hematologists is our university. Let's talk about why we need transplant center. That's the WHO report about cancer in the Eastern Mediterranean region. And that's the amount of money each country they are spending on patient with cancer. It's a reality, this is in 2009, that Saudi Arabia is not spending enough. It's clear. And now if you look at the Ministry of Health, the government, there's more and more oncology centers will be established in this country. Why? There is high demand. The number of patients with cancer is increasing. The spending of the government in 2009 was not enough. Lebanon was ahead of us. But I'm sure the next year, like what our president of the university yesterday, he would like to have this effort, excellent effort in the university to be amalgamated into one big oncology tower or oncology center that serves the country interest. In the Middle East, the most common cancers is different from international numbers, and you can see that breast, of course, all over the world, but there are other cancers that are more common, like the oral cavity cancer is common after the cervical cancer in women. But bladder cancer is common in the Middle East, and we will talk about why. For Saudi Arabia, the most common cancer is breast, colorectal, and we have, alhamdulillah, colorectal chair led by Prof. Shaheen. But look at number 3 is lymphoma, number 4, leukemia. And we know as a fact that these two diseases, if the patient relapse or from the beginning, certain patients, they are candidate for bone marrow transplant. That's why we should plan to have more and more transplant centers. And thyroid cancer, which is not a bad cancer compared to other cancers. That's unfortunate part, and that's why we have this conference. Most of our patients, they are diagnosed in advanced stage. Look at breast cancer and cervical cancer. This report, WHO report, is comparing Saudi Arabia with Egypt and United States. Most of the cases in the United States for breast cancer, they are picked up localized, early detection, which means high chance of cure. When it comes to Saudi Arabia, look at the regional and distance. So this comes to 71%. So 2/3 of our patients, they are diagnosed late, which means bad outcome. And that's why we have this conference. And tomorrow is the public session, increasing public awareness of importance of early detection of cancer, because early detection means better outcome. And that's the accredited cancer institution in the Middle East. And tomorrow we'll address two important issues why we have more cancers: diet, obesity, and smoking. So two important risk factors, and unfortunately, look at Saudi Arabia. This is prevalence of smoking among males more than 15 years and females, 22%, 1%. Obesity, 62%, 63%. Don't say among female it's 1%, it's nothing. No, everything will start as a small. If you don't observe, if you don't counteract, if you don't stop, this phenomena of smoking among female will increase. So we need to have campaigns of anti-smoking measures. That's why in our region we have this infection-related cancers, schistosomiasis. Still, it's a problem. And that's why we have bladder cancer as common cancers in the Middle East. H. pylori, HTLV1, HPV, hepatitis, and EBV. All these cancers and infections, we will hear about it tomorrow. What about now stem cell therapy? Is it a hope or a hype? No, I think stem cell therapy is a hope, not a hype. Stem cell therapy for hematological and genetic diseases has been there for decades, but stem cell therapy is expanding due to the concept of stem cell plasticity. In cancer, targeting stem cell will eradicate the cancer completely. In regenerative medicine, which is a new era of stem cell therapy, is investigational, but it is rapidly progressing. In plastic, in dermatology, clear like baldness, many diseases is now treated with stem cell therapy. The first real stem cell therapy that was carried out was in 1940 during the World War II, when the pilot who dropped the atomic bomb on Hiroshima and Nagasaki, because there will be explosion and radiation, so the army, they collected the stem cell of the pilot and kept it in liquid nitrogen. So there will be no aplasia to the pilot. However, the pilot went, dropped the bombs, killed 200,000 people, and went back to the base. He was not affected by the radiation, but many people were killed by this radiation. But if you go to literature, the first autologous bone marrow transplantation was in 1953, first allogenic, successful allogenic bone marrow transplantation was in 1970s, and cord blood was in 1990s, and stem cell therapy in other than hematological malignancy started in the 21st century. Stem cell is the origin of disease, and stem cell therapy can be the cure for many diseases in the future, especially degenerative diseases and repair of tissue. The current indications, approved indications of transplant is leukemia, lymphoma, myeloma, bone marrow failure syndrome, aplastic MDS, and genetic diseases, and rarely in solid tumor. But the future indications of stem cell in regenerative medicine, repair medicine, geriatric, anti-aging, including Alzheimer, and cancer stem cell targeted therapy. But there are many unleft questions or unanswered questions that our next generations of physicians and students, they have to answer carefully in order to practice carefully. Which cells? Is it stem cell, mesenchymal undifferentiated cell, or side population cell, or induced pluripotent cell, or stromal cell? We don't know. What dose? For bone marrow transplant, we say 1 to 2 million per kg, but for regenerative medicine, what dose? What route? Is it IV? Is it sub-Q? How frequent we should give these stem cells? When to do it? How to do it? Which cytokines? There are many unanswered questions that needs answering. Last point, which is patient advocacy. I'm a patient advocate. And then when we search for match and related donor, and this registry, International Bone, Blood and Marrow Registry, they said it should be volunteer. And nothing with this economic strain that will come volunteer. So from patient advocacy, I have no problem of paying incentives to donors. And there is clear lawsuit in the United States, and I'm sure it will change, because they are comparing this to kidney donation. No, kidney donation, the donor might be affected. But in stem cell, there is regeneration within few days, within 1 week. So why we don't allow donors to come forward, let them get compensation? They are losing time, and that's from my patient advocacy perspective. We should encourage population to come forward, not only for blood, for stem cell donation, but also for blood donation. Although if you go to AABB, this is violating many of the AABB principles. That's our future for our young doctors. Just you need to be a hematologist. That's the stem cell therapy. The first patient is cardiology. He had MI. He's getting stem cell infusion. Next patient is a stroke patient. She is getting stem cell infusion. So in the future, what we need our dean and hematologist. Thank you. I will stop here.
Thank you so much, Dr. Beiruti. Very informative lecture, and thanks again for being on time. We started 10 minutes late, but I think we are back to the time. We know we still have a session after the lymphoma module, so without any delay, we'll Dr. Hani Hashmi, his next presentation about the AML and molecular era.
Bismillah ar-Rahman ar-Rahim. Good morning, everybody. Thanks for the invitation again. I have few declarations I have to make before I do the presentation. First of all, I don't have any relaxation slides as Bassem was doing. So this is number one. Number two, I know molecular biology is something that not too many people like to have in the first thing in the morning before breakfast. So I'll try my best not to have any detailed paragraph or figures in the presentation as well. So with that, I'll start with my first slide. So the outline of my talk, I'll have a few slides on introduction, and then I'll talk a little bit about the known molecular markers, and then the new molecular markers, potential utility of those markers, and I'll end with a few slides on conclusion. So acute leukemia, as we all know, is a relatively rare cancer, thanks God. Median age around 60. In younger population, the incidence is fairly low, 2 to 3% per 100,000. However, it goes up to 13 to 15% per 100,000 in the 7th and 10th and the 8th decade, and it goes higher as patient grows in age. It's highly heterogeneous in terms of morphology, cytochemistry, immunophenotyping, cytogenetic, and also molecular markers. You see here the data from the Sears data from 2005 to 2009. And again, the rate for all races depend on the age below 65 and above 65. This is also distribution of the cancer, myeloid cancer, lymphoid leukemias, myeloid leukemia, depending on the sex. And for the past 30 years, we haven't seen an increase in the incidence. And I don't know if I have a pointer I might use, but you can see the red dotted one is actually the chronic leukemia, myeloid leukemia, and the blue lines are actually the acute leukemias lines. So we're still in the range of 4 to 5%. So morphology of leukemic blast in bone marrow may not be straightforward, as most of the hematologists would agree on this, whether it's lymphoid, whether it's myeloid in origin. That's why we have more techniques actually to help us make the diagnosis. So cytochemistry was in the early days, and now immunophenotyping, cytogenetics, and more we'll hear about molecular as well. So in the past, for the past 20 years, chromosomal abnormality have been studied, and we know that about 50 to 60% of the patients who walk through the doors in the clinic with AML would have an abnormal chromosomal rearrangement. However, the importance of cytogenetics is actually fairly important when you talk about prognostication for first line and also after relapse. So what is the current expectation? In patients younger than 60 years of old, you would expect 70 to 80% of those to go into CR after induction with one or two cycles of induction. Additional courses are needed actually to reduce the relapse rate to 50-55%. So in general, you have a total of 45% of patients would be cured, hopefully with their acute leukemia to start with. And you can see on this graph, over the past 30 or plus years, the survival of patients with AML have improved from being 5% to being in the 50th percentile range and probably higher for few subtypes of leukemias. Most of this improvement has been actually related to better understanding of the disease biology and also for better supportive care that takes patients through the neutropenia period with the induction therapy. Unfortunately, this is not the case if you talk about elderly patients. So patients above the age of 60, most of those curves are actually superimposed, although maybe you would argue that maybe now we're doing a little bit better with the targeted therapy. So we're curing about 20% or less. So we'd expect half of those patients will achieve remission with induction chemotherapy. And unfortunately, most of them would relapse within 2 years. Cytogenetics, as we all know, have major prognostic values, and you can see all different groups throughout the world, UK groups, North American groups, Jemima, Italian, and German group have identified different cytogenetics risk factors goes from favorable, intermediate to adverse, but they all agreed on the very first one, on the favorable, that's core binding leukemias do better than others. And core binding leukemia constitute about 20% of the patient, which is very good prognosis. However, of those core binding factor leukemias, there is about 30% of the patient would harbor the c-KIT mutation, which tyrosine kinase mutation that actually increase the risk of relapse, takes it from 40-50 to about 70%. The problem we left with a very homogeneous group in the middle, which is an intermediate group that all of them has normal cytogenetics. And remember, about 60% of the patients fall in this group. 70% of those will have normal cytogenetics. So although the cytogenetics was very informative with the favorable and the unfavorable adverse prognostication, but in the intermediate, we still have a lot of things to do to actually re-stratify the patients. So what do we know about the current ones? So in the recent years, gene mutation and deregulation epigenetic of genes had been identified. This actually improved the insight into the mechanism of leukemogenesis and revealed a lot of molecular markers within distinct cytogenetic groups. So for example, in the normal cytogenetics group, now we have a lot of mutations that we can test for that can actually predict outcome. And as we know, since the PCR was actually developed in the year 2000, and after that, there is a lot of techniques had been developed, and now more and more techniques that become more available, hopefully will be in the clinical use in the near future. So to date, the only three that most of the hematologists know and would probably order on a routine basis, the NPM, nucleophosmin, the C enhancer binding protein, alpha, and FLT3 mutation that's actually available for clinical practice, what you can use in the clinic. And it does affect diagnosis, risk assessment, and also guidance therapy. And you can see on this table here, this is the most recent, it's a 2008 WHO classification of acute leukemia. On this basis, clinical, pathological, and biological feature AML with MPN and mutation, and AML with C binding protein A alpha mutation have been actually incorporated into this for the first time. And you can see that it's actually one of the favorable cytogenetics / molecular to have. Although FLT3 mutations are not considered as a definite entity in the WHO classification 2008, we know a lot of FLT mutation that it might have an impact on patient relapse-free survival as well as overall survival. And you see from this graph, this is a group of patients that had mutated NMP without the mutated FLT3, and I'll talk a little bit about FLT3 in the next few slides. They do better if they don't have the FLT3 mutation compared to others, which is the black ones. That's a group of patients that did have the mutation as well. So MPM mutation without the FLT3 mutation is a good thing. And there, as you know, there is a lot of targeted therapy that has been developed for FLT3 inhibition. Okay. So this is a fairly nice publication in New England Journal a couple of years ago that looked into normal cytogenetics patients, acute leukemia, and tried to look at most characteristic molecular marker with those patients. So you can see that a lot of patients would have an MPN mutation, which you can see in the top, and the others actually in different frequency. So MPN is probably the highest, and then FLT3 is actually second, and then the C binding protein alpha is actually the third. So it gives you an indication that those normal cytogenetics by chromosomal karyotyping probably harbor molecular markers that of an interest. So I'll talk a little bit about each one in the next few slides. MPN mutation are found approximately in about a third of the patients with acute leukemia. It is associated with recurrent genetic changes, secondary chromosomal abnormalities such as trisomy 8, 4, deletion 9q. It also can be seen in mutation with mutations such as FLT3 mutation and IDH iso dehydrogenase mutation. So what about its prognostication significance? I talked earlier about mutated NPM1 without the FLT3 internal tandem duplication mutation. It has been seen in many, many trials that it actually have a better outcome in terms of overall survival and also in terms of relapse-free survival. So for that reason, you see that the newer publications are actually quoting this actually as one of the good favorable mutation to have when you stratify patients with acute leukemia. What about therapeutic implication? So we do treat them pretty much similar to the patients with the core binding factor AMLs. So they get the standard induction, they get 3 to 4 cycles of high-dose Ara-seq as a consolidation, and they do just as well as the core binding factors. There are studies that actually looked into autologous transplantation for those patients, and they do benefit from autologous transplantation just as much as they do from high-dose consolidation. The interesting thing about NPM1 mutation, we talked about the bad prognosis of patients who have AML and old age. NPM mutation itself is actually a good predictor for outcome in older patients, so even in older than 70 years old. So it's fairly important to test for mutation in older patients who have normal cytogenetics, because they might actually benefit from having chemotherapy and intensified chemotherapy as well. So I'm showing the graphs that I showed earlier, the NPM with FLT3 negative, and you can see that those groups do much better than other genetic groups. And again, in terms of event relapse-free survival and in terms of overall survival. Do they benefit from transplant or not? So they looked into whether patients who have donor and the mutation who were transplanted or who actually was not transplanted received only consolidation therapy. And as you can see from this graph here, if the patient has a mutation without the FLT3, if they have a donor and went for transplantation, they did not actually fare better than the one who had only consolidation. So based on this publication, the recommendation is actually not to go for allogeneic transplantation in those good risk patients. And you can see the difference in whether you have a transplantation or not in other cytogenetics. So if you have a donor and you have a transplant, outcome is better. But specifically not in this mutation. So what about the C binding protein alpha? It encodes transcription factor, which is very important in hematopoiesis. It's actually present in about 10 to 18% of normal cytogenetics AMLs, and about 40% of AML with deletion, 9q deletion. There are two major heterozygous C mutation, C binding protein alpha mutation, that I'm not going to talk about here. So what about the prognostication of this marker? It has been always consistently shown to be a good, favorable outcome in terms of better, higher CR rates, better relapse-free survival, and better overall survival. A recent study shows that one of the two mutations is actually better than the other. So if you have the double mutation, biallelic mutations, those patients do better compared to a single one allele mutation, which is actually the predictor. So now we look for the biallelic when we look at molecular marker for those mutations. So therefore, with regard to disease classification and risk stratification, only AML with double mutation are likely to have a favorable prognosis. And you can see it here. What about therapeutic implications? So similar to those with core binding, similar to those with MPN1 without the FLT3 mutation, the standard is actually induction followed by consolidation. AML with double mutation, C binding protein alpha mutation may not benefit from allogeneic transplantation. This statement is currently not supported by the data. However, the assumption in general that patients with favorable risk do not need transplantation, do not drive a benefit in the first CR. FLT actuation, I'll just try to go over it fairly quickly, is that it's a constitutive activation mutation that have actually proliferative advantage of the leukemic cells. It found in 20 to 30% of the patients with AML. There is two different kinds of mutation, the internal tandem duplication, which is the one we look for, and there is tyrosine domain mutation that's remained controversial. Nobody knows the significance of that yet. Therapeutic implication, it's still a clinical dilemma. However, we think there is a lot of evidence now supporting the use of allogeneic transplantation for those patient populations that's at higher risk for relapse. There is also ongoing phase 3 trials looking at FLT3 inhibitors in combination with first-line chemotherapy. So the nuclear marker, a fair statement to say is all of the genes that I'll talk about in the next few slides are not yet in the clinical practice. Most of them are investigational. KIT mutation, I spoke earlier about the core binding factors, and having a core binding factor with the KIT mutation actually confer worse prognosis compared to those who don't have the KIT mutation and have the core binding factors. So it's present 25 to 30% of the patients. It's fairly rare in other subset. It's actually confer an inferior outcome of those patient population, unfortunately. IDH1 and IDH2 mutations, thing that I wanted to say about it, it's about actually 25% to 30% in patients with normal cytogenetics AML, and it does actually bring a new insight into leukemia because it's actually can affect metabolite. It actually can affect an enzyme that that actually cause accumulation of metabolite that is actually potent and fairly oncogenic. I'll move to Wilm tumor mutations, 10 to 13% of normal cytogenetics, inferior outcome as well. MLL mutations, 5%, 5 to 11%, and also inferior outcomes. DNA methyltransferase 3A gene, found in 20 to 25% of AML. It's independently associated with poor prognosis. The exact mechanism of its action is not well elucidated yet. The TET mutations occur in about 10% of patients. It's closely related. You can see it in older ages, high WBC count, blast count. And again, it's confer a negative impact on outcome. The last one in those mutations are actually additional 6 COMS-like one. It's typically seen in secondary AMLs, about 30%, but you can see it in de novo AML, in normal cytogenetics. And again, it's confer a poor outcome. This is the last one I'll talk about, the PHF6. It's a loss of function mutation, tumor suppressor gene, and it's confer a bad prognosis. Potential use, there is a lot of retrospective data that has looked into molecular markers. Some of them actually developed their own stratification modules based on their current data, but I guess the largest one that was actually came recently from the ECOG group, where they looked at around 500 patients and they looked at all their molecular markers. And you can see the molecular frequency, the higher frequency in those, almost everybody had the mutations out of all the cohort patients. FLT3 was the highest, then MPN, DNA, methyltransferase, and the list goes on. methylation complementation. Some of those actually was exclusively mutated, and some of them have co-occurrence. And I'll go through this slide fairly quickly. So if you have an I2D1 or 2, you have an IM with that, there is a co-occurrence with that, and same thing with the DNA methyltransferase. There's 3 other mutations that you can see it with that mutation. However, if you have an IDH1, you don't have the TET2 mutations, and if you have an IDH1, you don't have the Wilm tumor mutations. Okay. So with the molecular determinant overall survival, on a univariate analysis, looking at a fairly specific group, positive for FLT3 internal thalamic duplications, mutation did actually impair, certain mutation actually impaired overall survival, specifically the MLL mutations in those who do not have the SIBA mutation, whereas the SIBA mutation, even though they had the FLT tandem duplication, had better outcome. Again, looking at negative FLT3 I2D mutations, those who have the IDH1 did better compared to the TET2 and AXL and MLL and all the other poor prognosis. So this is the schema, the prognostic schema they actually postulated. They are actually moving certain molecular marker to be in the favorable, and certain ones will go into the unfavorable. And this is the newer, based on what they postulated. We'll go to the very last one. I'm just going to go to the, okay, with the high dose affect overall survival. High dose does affect overall survival depending on molecular markers. So certain molecular markers will be affected with high dose therapy. I guess this is one of the take-home messages. Mutation analysis also revealed that patients with certain mutations, specifically DNA methyltransferase, NMP, and MLL, have an improved survival with dosed intense chemotherapy, and there is absolute improvement of survival at 3 years of 19%. So it's something that physicians need to look into. My conclusion slide: the accumulation of molecular information provide powerful additional prognostic information and add further layers of prognostication insight within the cytogenetic strata. This is not only to refine prognostic information, but also will help in developing new targeted therapy. And the challenge to be is actually to provide those in a timely and affordable manner that everybody can actually prescribe. And I'll stop here, and thank you for listening.
Thank you so much, Hani, for being on time. I would like to thank Dr. Shahin, Dr. Bayouti, and Dr. Shadi for inviting me today to be a curative speaker. I talk today about diffuse large B-cell lymphoma today and tomorrow. So, as you know, diffuse large B-cell lymphoma is the commonest non-Hodgkin lymphoma, and we see a lot of cases. So objective today is to identify the importance of the clinical prognostic factors, biological factors, and markers in diffuse large B-cell lymphoma, and to see if there is any alternative to CHOP chemotherapy, which is the standard for treating diffuse large B-cell lymphoma. So this is a familiar slide. I'm sure you've seen it before. Diffuse large B-cell lymphoma is the most common non-Hodgkin lymphoma. The incidence of, or the peak incidence at age of 60. Large cell under the microscope, and they may present as extranodal disease in cases mostly with the GI, with the stomach. We can see it also as a CNS lymphomas, testicular lymphomas, and skin involvement. We do have something special about the diffuse large B-cell lymphoma. They can have the mediastinal variant, which is a disease present in young patients. It's curable in about 50% of cases, and the median survival weeks to months if not treated. So this is again to see how common is the diffuse large B-cell lymphoma. Accounts for 30 to 35% of cases in North America. We don't have the exact statistics in our population, but roughly we see about 50% of cases mainly diffuse large B-cell lymphoma. We don't see much of indolent lymphomas. This is the 2008 WHO classification of diffuse large B-cell lymphoma, or large B-cell lymphomas just only. And we have this entity we call the diffuse large B-cell lymphoma, not otherwise specified, so the pathologist cannot put that category under any of others. For example, we have the diffuse large B-cell lymphoma subtypes. They can say it's a T-cell, rich T-cell lymphoma, or it's a primary diffuse large B-cell lymphoma from the morphology and immunohistochemistry and immunophenotyping, but sometimes they would say just only diffuse large B-cell lymphoma, and they cannot put it under of these categories. So molecular changes associated with diffuse large B-cell lymphoma, we have the commonest are BCL6 and BCL2 in about 40 to 60%. Also the c-MYC, which is the hallmark of Burkitt's lymphoma, can be seen also in 15% of diffuse large B-cell lymphoma. So how can we stratify patients based on clinical factors? We have patients with diffuse large B-cell lymphoma, say advanced stage. Would you tell just from the clinical presentation how bad or how aggressive is his lymphoma? We have this study which was done and published in 1993. It's a multi-center patients involved with a large B-cell lymphoma. It was anthracycline-based chemotherapy we were given to them, and they came up with these factors which they summarized as apples, so with one P. So A stands for age, P performance status, L LDH, E extranodal is a stage. And you can see the table just in the left corner. If you have 1 or 0 to 1 factor, they call it low. If it's 2 factors, they call it low intermediate. If it's a high, it's 4 to 5 factors. And you can see also the overall survival at 5 years impacted by the number of the prognostic factors. So if you have high, poor prognostic features, then the overall survival is about 30% compared to 73, and this is in advanced stage. This also was validated into the rituximab era, because that was a study that was done initially was in a pre-rituximab era, and it showed that even adding rituximab would have the same effect among all these categories, but still that differences between IPI-1 and IPI-415 still there and was not eliminated by adding rituximab. So clinical prognostic models is easy to use for clinical practice, so it's easy to calculate that from the age, from the status, performance status, and from the blood work and from the stage. And there's a marked variation into the outcome, as we as I just mentioned, with the factor 0 to 1, overall survival about 70 compared to 30% when they have 4 to 5 factors. But it's limited ability because you cannot define a very, very high risk, because there is still some biological factors that might play a role into the pathogenesis of diffuse large B-cell lymphoma. But it remains as a surrogate for biological heterogeneity. So, are there reliable biological markers to tell if this patient with diffuse large B-cell lymphoma would have alternative cause compared to other one? Gene expression profile. This is a genomic expression is one of the powerful techniques where they have thousands of genes. If you take the tissue from a patient with diffuse large B-cell lymphoma, they can tell, and that was also divided the diffuse large B-cell lymphoma to 3 groups. One they call the primary mediastinal large B-cell. The second one is the germinal central B-cell lymphoma, and the third is activated B-cell diffuse large B-cell lymphoma. And you see how is the outcome is different among the 3 groups. So those with the primary mediastinal, they did much better than those with the germinal and activated B-cell type. So the activated B-cell type diffuse large B-cell lymphoma only have the worst 5-year overall survival compared to other. From this slide, you can tell how would be useful to tell which patient or which subgroup initially at the time of the presentation to see if there's anything can be done differently to those patients. This gene expression also was tested to see if they can predict the response to the chemotherapy, and this is a study was presented in ASH 2011. They used archived tissue from the study, which was initially done about 10 years ago, testing the role of maintenance against rituximab in diffuse large B-cell lymphoma, and it was negative, that study. But they talk about 183 patients, and they did a gene expression on that archived tissues, and they came up with a 6 gene for R-CHOP and 5 genes for CHOP. Those who have a poor prognosis, if you see into the right side of the R-CHOP, you have the yellow and the blue. The blue, they have less gene expression compared to the yellow, and the same into the CHOP era. So they can predict which patient would respond to chemotherapy based on that gene expression profile. But it's not routinely available into the patient care now because lack of standardization of the commercially available kit for the gene expression, and it required also fresh frozen tissue. But this, in the future, it would change the treatment of diffuse large B-cell lymphoma. So what about immunohistochemistry? This is a model which was developed by Hans, and this is published in 2004. They are trying to tell what is the subtype of the diffuse large B-cell lymphoma based into the immunohistochemistry. So not using the gene expression, because I said the gene expression is commercially not available, and this can be done into the lab. But one of the advantages of using the immunohistochemistry can be done into the paraffin embedded tissue. It's universally available, it's reasonable cost, and measures the protein expression, which is the end product of the oncogene. So if they have a CD10 positive, this is a germinal center. If it's a negative, then they go to do BCL6 and MUM1 protein. But the disadvantages of that immunohistochemistry is there is a variation into the staining and variation into the scoring of that, and that's different from lab to lab. And this is confirmed by this study where they took 16 tissues from 16 patients and sent to 8 labs in different countries, and also led by 9 pathologists. And it showed there is also no agreement except into the second round when the pathologists have another look and into the scoring. CD20, there was almost agreement, but if you go down, there is still disagreement into the BCL6-2 and the MUM1 and the BCL2. So from this slide, you can tell how difficult also to have agreement universally in scoring or staining immunohistochemistry for diffuse large B-cell lymphoma. One of the examples as a biological factor is the BCL2, which is the anti-apoptotic factor, and it's present in about 40 to 60%. That BCL2 in the past was told it affected the overall survival of diffuse large B-cell lymphoma, but that effect, so those with the BCL2 initially positive, they have a poor prognosis compared to BCL2 negative, but when rituximab introduced into treatment of diffuse large B-cell lymphoma, that effect or the poor effect of BCL2 was eliminated. So those who were treated with the R-CHOP have the same overall survival, either positive or negative. But recently it was published that diffuse large B-cell lymphoma, so we have 2 pathways. We have the germinal center and we have the activated B-cell type. So I'm trying to tell in this, or to say in this slides, is BCL2 expression can be done in 2 pathways or 2 mechanisms. First of all, by translocation, which is the commonest 14-18, but it can be also amplified through another pathway, they call it NF-kappa B. So it depends into the mechanism of the expression of that BCL2, it will tell if they would respond to the R-CHOP chemotherapy or not. So you can see it into the left side, it was non-prognostic by introducing the R-CHOP, but when given just only a CHOP, it was prognostic. So it's still into the same dilemma again, but this is also in the future can be used to tell if there is any resistance to the rituximab or to treat those patients with translocated BCL2 different from BCL2 was expressed through another pathway. So role of the CMEC, as I said, the CMEC is a hallmark of Burkitt's lymphoma, but can be seen in about 15
1 minute.
5 to 10 minutes of diffuse large B-cell lymphoma. The role is to promote the cell growth and proliferation. Usually the CMEC is identifying this patient by the cytogenetic, but recently there is a histochemistry where you can divine also CMEC. So this is also a study when they found the CMEC translocated in about 11 persons by the cytogenetics, but by using the immunohistochemistry it was about 33%. So there is another different mechanism of that amplification of the CMEC. Why CMEC is important? Because if you have the double hit disease, when you have a BCL2 translocated and CMEC translocated, they have a poor outcome compared to other people where they don't have any translocation. So the double hit that's the CMEC and BCL2. The yellow line is for people who does have CMEC and BCL2 but expression due to amplification and not due to a translocation. When should we consider alternative to the R-CHOP chemotherapy? So the standard now for the chemo, for the diffusing large B-cell lymphoma is to give R-CHOP. For those who are not familiar with the R-CHOP, is rituximab, cyclophosphamide, doxorubicin, oncophene, and prednisone. And this is the regimen how it's given by the cyclophosphamide, as I said, bleomycin and cristin. It was introduced into the treatment of diffuse large B-cell lymphoma in about 30 years ago, and this is the SWAG study, which is one of the landmark studies, tested the CHOP compared to a traditional regimen in the past, and it showed they have the same time to treatment failure and same overall survival, but the R-CHOP was less toxic. So since then, the chemotherapy is CHOP is the standard of treatment with diffuse large B-cell lymphoma. This is another landmark study by Kovier, the JELA study, and this is introduction of the rituximab in 2002. So almost over the last 10 years, we are using R-CHOP chemotherapy, and this is the 10 years follow-up from that study. It showed adding rituximab to the CHOP chemotherapy improved about absolute improvement in 16%, and you didn't see that figure in oncology usually to have that overall survival benefit. Anyhow, so the standard now for diffuse large B-cell lymphoma is 6 to 8 cycles of R-CHOP chemotherapy in advanced stage. Studies were trying to compete the R-CHOP chemotherapy every 3 weeks, so they tried different modalities by giving R-CHOP every 2 weeks, or adding etoposide, or using another regimen they called ACDB by adding bleomycin. All these studies failed to compete the R-CHOP chemotherapy every 3 weeks in diffuse large B-cell lymphoma. And the study, which is the RCVP, is by the JELA study. It showed progression-free survival and overall survival benefit compared to R-CHOP, but it was more toxic, and it was in a young people, and it was an IPI of 0 or 1. Utility of autologous transplant into the first remission of diffuse large B-cell lymphoma has been tested and showed no benefit. And this is also, they were trying to test the autologous transplant after a few cycles of chemotherapy, either with R-CHOP 14 or CHOP with etoposide. And also it showed no overall survival except one study, and that was only a high-risk subgroup. So till this time, we treated patients with advanced large B-cell lymphoma with 6 to 8 cycles of R-CHOP chemotherapy. So in conclusion, most of the patients have a curable disease, about more than 50%, and clinical factors able to identify very high risk, but this is a useful utility that can be used in the practice. No validated biological markers, despite all the explosion in technology and all these advances, and the dual translocation of the CMEC and BCL2 should be considered for alternative treatment as treating as aggressive lymphomas. Thank you so much.
So sincere apologies, Dr. Barak. I have to prompt you for the next speaker. So with great pleasure, actually introducing Dr. Mohammed Kelta, a consultant, Department of Medical Oncology. He's the head of adult bone marrow transplantation in King Faisal Specialist Hospital Research Center in Jeddah. He's well published in American, European, and international journals, and he will speak to us today about the role of transplantation in multiple myeloma.
I would like to thank the scientific organizing committee for inviting me to participate in this fantastic event. And special thank to my office mate, Dr. Basim Beruti, and my dear colleague. The business of transplantation in multiple myeloma has evolved rapidly over the last, I would say, 10 years. If you look at the field of multiple myeloma, especially when it comes to transplantation, compared to other fields. And this is no offense for the lymphoma business. I mean, we have been dealing with CHUM for many, many, many years now, and the only addition I can see for diffuse large B-cell lymphoma for the last maybe 10 years is rituximab. But when we compare to this evolving business in multiple myeloma, you see those now proteasome inhibitors, the most recent ones are oral agents for proteasome inhibitors. We've seen monoclonal antibodies, and we've seen vaccine, dendritic cells vaccines. So in my presentation for the next 20 minutes, I will just present the well-established practices and not the experimental ones. Okay, and toward the end, I will give my summary of presentation. As a reminder, before I start, tomorrow we are reviewing our guidelines in hematology. It will be at King Faisal Main Auditorium from 4 to 7, and we would like to welcome on board anybody who would like to participate. So, good. Bone marrow transplantation or hematopoietic stem cell transplantation, as Basim would like to call it, is not a magic bullet in terms of multiple myeloma. Before you consider autologous transplant for somebody who's candidate age-wise and organ-wise, you would like to achieve the best response before you take them for transplantation. That's why we call it debulking procedure. So in order for you to achieve the best debulking procedure, you really have to choose the best either single or combination agents to reach to that point, what we call it very good partial response, or at least partial response before we take it for transplantation. Now there are different studies here, we call it, and those are all, for the most part, large and international studies. In each one of those studies, if you achieve CR, or very good partial response, that's to say, less than 9% residual disease, the outcome when it translates to overall survival is better. So the depth of response is very important, and this is illustrated in all those studies. If you look at the NCCN guidelines of most recent ones, 2012, and you're facing multiple myeloma patients, you have at least 10 different options that you can choose from. And they are all right, even though they are given different categories because of difference of opinion. But anyone you choose is right. To make it easier, there are some certain guidelines. For those who have high-risk cytogenetics, you have to add bortezomib. And I'll show you why we add bortezomib for high-risk patients, mainly cytogenetic abnormalities. For those who have standard risk patients, it is okay to use thalidomide dexamethasone. And in fact, at King Faisal in the past, before we adopted the cyclo-D, that's cyclophosphamide, bortezomib, and dexamethasone, we used to use thal-dexa for all comers. Now, perhaps we are shying away from this protocol, and we are doing more of bortezomib-based regimen. So, if you have somebody with risk abnormalities, you have to use bortezomib. It will overcome the poor outcome of abnormal cytogenetics. For those who are standard risk, you may choose thalidomide, dexamethasone. Now, again, that is not completely killed protocol. Now there's not a new development, but I would say there's a concern about, instead of using adriamycin, liposomal adriamycin has been used in the VAD regimen, and it is considered here as a category 2B. So there's a chance that you may use that VAD or VAD modifications. Again, the collective experience with bortezomib as a single agent, as a proteasome inhibitor, single agent will give you in the range of 60%, this is highlight here. So 60% overall response rate with only 3% CR. So single agent bortezomib is probably not enough, even though it's one of the best agents we use in combination. So when it's combined with dexamethasone or liposomal adriamycin, it gives you better overall response rate. We're talking about 70 to 80%, and we're approaching 28% CR and near CR. Even you get better outcome if you combine Velgate with other agents like immunomodulators such as revlimide, lenalidomide, or thalidomide. Here in one small study, 100% achieved overall response rate on revlimide, Velgate combination regimen. Here 80% with Velgate thalidomide. So it sounds like Velgate when combined with immunomodulator give you the best outcome. Okay? In terms of achieving CR and near CR. data. I think in this one, the first 3 publications came from Mayo Clinic by Raj Kumar, and also combined thalidomide. You need an opener. Bassem used to say, if you need to use immunomodulator, you need an opener. And I think this is very right statement. You need dexamethasone, you need some other agents to use. Thalidomide plus dexa, lenalidomide plus dexa, again, two publications, lenalidomide plus dexa by the same author. And they came in with overall response rate in the order of 75 to 80%, and CR rate for dexa in this study especially was 26%. This is good. This is when it comes to protocol, this is a safe protocol, less toxic. To achieve CR of 26%, this is an achievement. Now, this is a fascinating concept when they added clarithromycin. Clarithromycin added to the current protocol of lenalidomide and dexa, and they had, even though this is a small study, they achieved overall response rate of 90% and 39% CR rate. Now, this is still investigation and not one of the standards. Okay, and that's how they necessary. Now, you have your patient. You identify this as a candidate for transplantation. You give him your best bed with a best combination regimen to achieve either CR or very good partial response, or at least PR before they go for transplantation. What options now do you have? Single autologous transplant, double or tandem autologous transplant, tandem auto-allo, tandem auto non-myelo, many options. Okay, we'll go quick over a couple of studies here. It was recognized early on by a talent from the IFM group that if you compare autologous transplant, single autologous transplant versus conventional chemotherapy, remember those publications came in 96, by then we were using the VAD protocol for the most part, right? Okay, and it sounds like if you compare transplant versus conventional treatment, definitely transplant give you better overall survival. From this study, it was very important to notice the difference was not recognized early, or it took time for the difference to show up. So at least you have to have 4 to 5 years before you assess the overall survival curves for any myeloma study, okay? And so the difference was not appreciated until after 30 months here. Another study, 6 or 7 years later, reported by another group, and they exactly showed that if you consider stem cell transplantation autologous, one single transplant, versus conventional treatment, by then, you buy 1 extra year. So it's not a curative. Again, stem cell transplantation autologous is not curative, but it buys you more time, at least on average year, 1 year added. If you look at this now, the old regimen, VAD regimen, the one we used to be one of the standards treatment in the early, late 90s, early 2000. VAD protocol was compared to this regimen with PAD. PAD is bortezomib and adriamycin dexamethasone. So they have 2 randomization to either PAD or VAD, including Vilgate. And they underwent stem cell transplantation in both arms. Those who received bortezomib upfront continue to receive bortezomib as a maintenance. And this is one of the few studies where bortezomib was used upfront and in the maintenance settings. The other one was VAD, stem cell, and then thalidomide maintenance. In this study, at all phases of treatment, those who had bortezomib, whether this is following induction treatment, following high-dose chemotherapy, stem cell transplantation, and maintenance, overall response rate was 78%, increased to 88% after transplantation, and continued to increase to 91% after maintenance. By all means, there's a trend toward improvement in terms of overall response rate when bortezomib was added. To less extent, however, VAD did the same. Now, from this study, again, when we compared Vilgate-based regimen versus a standard at that time, bortezomib patients fare better in terms of progression-free survival and overall survival, and less, after achieving better deep response. Another study, this is fascinating because they use here double autologous transplant, and this is by a group led by Cao. This phase 3 study, they look at VTD now, Vilgate, Thaldexa versus Thaldexa. So Vilgate added to Thaldexa, and they had double auto. So induction will be VTD versus TD, double auto, and then continue with similar maintenance to induction for 2 months, and then they continue with dexamethasone. So VTD versus Dexa, stem cell transplantation, double or tandem autologous, continue to receive maintenance similar to induction for 2 months, and they continue dexamethasone as single agent maintenance. In this study, again, all throughout the phases of treatment, whether this is induction, first transplant, second transplant, and maintenance, again, those who received bortezomib-based regimen fared better than those who did not. Okay? Fascinating in this study, they were able to show that if you use Vulgate-based regimen, you can overcome, and that's what the mission initially, you can overcome the bad prognostic cytogenetics. In this study, they looked at deletion 13, which is one of the bad markers, translocation 414 by FISH, and deletion 17, one of the worst markers. And if you look at Vulgate-based regimen compared to VTD versus TD, Dexa, almost 75% versus 44% for CR near CR is significant, and also almost double for those who had 414 or deletion 17. So Vulgate added a better outcome for those who have bad cytogenetics, whether this is CR, near CR, or even 3 years progression-free survival. You're at about 60% versus 40% and 54 versus 40. So response rate and overall survival and progression-free survival was better for those who had bad cytogenetics but given Vulgate. By the way, I'm not affiliated with the Vulgate company. All right, tandem versus single in high risks and standard risk melanoma. This is presented in ASCO last 2012. Well, this is last year already, and they had high risk patient given either tandem transplant, we're talking about auto now, high risk tandem or high risk single, versus standard risk single. So either high risk tandem single or standard risk single. Fascinating from this abstract presented last year in ASCO, if you look at the response rate are across the border very much similar, but when it comes to relapse, take this focus on the high risk tandem, high risk single. The relapse rate was higher when single transplant performed on high risk patient. So bottom line, you have to do 2 transplants for those high risk from this presentation. And then also 3-year survival was better for high risk patient when given tandem. So suffice to say, high risk patient should undergo at least 2 transplants. For single transplant, however, for standard risk patient, however, you don't need double because they did very well with single transplant. So good patients will need only 1. High risk patient will need probably 2 out of this as a summary for this presentation. Now we consider single, tandem, now tandem, auto, non-myeloma. That's reported in an abstract form, ASH 2010. They looked at patients, they certified based on HLA. They have HLA MASH, and they're candidates for transplant. They will do 1 auto and then non-myeloma. If they don't have HLA MASH, they will do double auto. Okay? So this is based on an HLA MASH classification. They had a standard induction. Those who had HLA non-myeloablative, allogeneic, prepared with total body radiation or second autologous, if they don't have HLA MASH. Those who underwent, those who underwent double auto ended up with, again, another certification, randomization, either received thalidomide or Dexa or observation. So if they have donor, they will go auto non-myeloma, no donor, they will go auto. Those who have double auto will end up with, again, maintenance, either Dexa or observation. So from this study, interestingly, there was no difference in 3-year overall survival and progression-free survival between the transplant group, whether double auto or auto non-myeloma. So they're similar. But when it comes to chronic graft-versus-host disease, severe chronic graft-versus-host disease, more than 50% developed this complication. Again, when it comes to maintenance, there was no difference in 3-year progression-free survival. Whether thalidomide Dexa was used as a maintenance after double auto or observed. So probably after double auto, you don't need this sort of maintenance because you already intensified your treatment and that was good enough. Okay. Maintenance. This is a little bit, I left it
5 minutes.
Okay, I think we'll have this 5 minutes. A little bit more confusing actually how to tackle the issue of maintenance after transplantation, because you see that confusing published results, but I'll try to summarize it and make it easy for you to understand. Here I mentioned the 3 studies, big studies, one by the group from colorectal cancer, the other one of IFM, the third one by Spencer. They give maintenance after transplantation, different dosing. In this 2 first studies, they give 400 milligrams, which is considered high dose and rather toxic, especially when it comes to peripheral neuropathy, which I demand for those who deal with thalidomide. And the third protocol used 200 milligrams, slightly lower dose, with more tolerable toxicity, I would say. And then, you know, the first 2 studies give it till progression or adverse event, last study gave it for 1 year. Now, CR rate was higher when thalidomide was added. All 3 studies gave better progression-free survival when thalidomide added, but only 2 out of the 3, only 1 out of 3 showed overall survival. That's his first study. And that was relatively short follow-up. The largest or longest follow-up was probably for the FRESH trial, which did not show difference. So overall, I'm sorry, the biological group did not show difference, but the last 2 groups showed a difference in terms of overall survival. So a little bit confusing, and I'll make it a little bit more confusing when this meta-analysis published last year on thalidomide issue in terms of maintenance. Now, when it comes to lenalidomide, even more confusing because there are a lot of issues with lenalidomide used as maintenance. Lenalidomide is IFM, there 2 studies, one from IFM and the other one from NCI. This study used lenalidomide and patients decided after transplant either placebo or lenalidomide after short consolidation with lenalidomide. In this study, they were able to show difference in terms of progression-free survival. Median progression-free survival in this study for the lenalidomide arm was 42% versus 24% for the placebo arm. So almost double for those who received lenalidomide. But this, unfortunately, did not translate into better overall survival. So, despite the progression-free survival improvement, no improvement in overall survival when lenalidomide was used as maintenance. Okay. Let's try this way. This study was positive and in ACI study, they were able to show that if you use lenalidomide as a maintenance, it will give you better treatment time to progression and give you better overall survival. But, you know, borderline improvement, I would say, in terms of overall survival. I'm having a problem here. Okay. Again, 88% overall survival at 3 years for lenalidomide arm versus 80%. Still, they were able to show, unlike the IFM FRESH study, better overall survival, not only progression-free or time to progression differences. Okay. Well, this goes without saying that there is a lot of issues about lenalidomide. If you look at the IFM experience, the collective experience, they have looked at similar cohort, 300 on a placebo versus, I just mentioned that before, the IFM study of lenalidomide. In fact, when they look at the patients here, 11 patients have hematologic malignancies. Okay, versus 3 for those who were on a placebo, and for solid tumor, esophageal, colon, breast, basal cell carcinoma, breast, and prostate and breast, 14 patients. So collectively, they have 11 plus 14, 25 cancers, hematologic and non-hematologic, compared to 6 on a placebo arm. This is important to know. Those who have a high risk for solid cancers are those who receive lenalidomide, older than 55, advanced stage myeloma, and received some sort of etoposide-based regimen. In the FRESH trial, we would like to use DCEP. E is for etoposide. So those who receive etoposide, and it's known that etoposide is topoisomerase inhibitor, can trigger leukogenesis. Okay? So when added to lenalidomide, it sounds like this is a bad combination. Okay, now again from the CLGB trial, I did not go over the CLGB trial, that's a chemical B trial, but from this trial, when they look at the toxicity for, in fact, 45% for those who were on lenalidomide had significant hematologic toxicity, mainly neutropenia. 43% had neutropenia, and this is grade 3 or more. And when it comes to non-hematologic toxicity, a third of them had toxicity, and again, severe toxicity in terms of fatigue, rash, diarrhea, and so forth. So this is a big issue with lenalidomide. I think I will just come to the summary here. You know, we have different protocols to mention, and I think if, starting from the old standard of care, VAD, and now all the way we're going to Velgate, thalidomide, Dexa. To me, this is a very interesting slide. You know, with VAD, thalidomide, Dexa, without transplantation, we're achieving similar results to the old VAD plus transplantation. So it means simply considering active chemotherapeutic agents now can give you similar outcome to the old regimen where old VAD was used with transplantation. However, still there is an added benefit for transplantation, but not to that extent. Okay, so it sounds like the way that the gap is narrower now, and where maybe one day we might not need bone marrow transplantation. That's a message from this slide. A summary also, auto-BFT is still a standard of care as we speak today. We use non-melphalan, melphalan is known to cause stem cell toxicity, so we don't use it for those who are candidates for transplant. Peripheral stem cell is a preferred method for collection, and we try to collect, if we can, at least 6 million per kilogram, because some of them might end up doing or going for tandem transplantation. A second auto transplant, well, again, this is a clinical trial, but based on an AFM well-studied study, the clear-cut indication for a second transplantation autologous is, if not achieved, CR or very good partial response. So any patient who does not achieve after first transplant very good partial response or more is candidate for tandem transplant autologous. Myeloablative allogeneic transplant is scheduled with too high mortality. I remember those days when allogeneic transplant mortality was in US almost approaching 40 to 50%, and the arm of allogeneic transplant was closed. And this is the mid-90s, okay? Because of infection. Those are susceptible for infection, so it's no longer a standard, but still we can select patients for allogeneic transplant if they fit. Now, to minimize toxicity with allogeneic transplant, the notion of reduced intensity conditioning regimen is there, but again, this is investigation still. Maintenance, I touched bases on the maintenance. There was a I would say 6 studies collectively published in meta-analysis last year, and so 6 studies out of 6 all showed progression-free survival, but only 3 of them showed overall survival benefit for thalidomide. Lenalidomide shows too complicated. However, it still may be considered for somebody who achieved less than very good partial response to augment the response by adding lenalidomide for those who achieve less than very good partial response. With this, I will end up my presentation.
Thank you, Dr. Filter. Dr. Kafir, Dr. Beiruti, if you want to come to the podium here for question and answers. We'll have a few questions for 5-10 minutes, and then we'll close the session for the break. So if there is no question, I have a question to the hematologist in the room here. Molecular markers, are we, here in Jeddah, for example, do you guys send it outside or it's locally done?
Dr. Ghazi, please answer, please. You don't know anything about this. Actually, Dr. Ghazi is my senior colleague. He is the chairman of the King Fahd Medical Research Center And actually this week on Sunday we had a trip to it changed. It used to be King Fahd, now inshallah it will be something different. And Dr. Ghazi will answer all these questions.
Bismillah ar-Rahman ar-Rahim. Actually, I'd like to welcome you all really to King Abdulaziz University. Dr. Kelta, welcome back.
Thank you.
Actually, we missed you all these years. I'd like to tackle the subject in a general way. That from your all presentations, we can see that cytogenetics, moleculars, and all these are now very important to certify most patients to high risk, moderate risk, or low risk, and that definitely will help the physicians to take the decisions which type of treatment is going to use. And nowadays, as we know, that the drugs are very, very expensive, and you can see, thalidomide, and the difference between the prices between thalidomide and lenalidomide, for example, and other, they are really huge. And I think we have special situations here in let's say, in the third world. So I think it is important, really, for the whole institute, and I'd like to thank King Faisal, really, because they are taking the lead to take that action in standardize. We'll look at each disease, like I know that they tackled M3, for example, leukemia, and now multiple myeloma. So this is what we need. That's these people to come and to tell us, to tell all the physicians what types of molecular we should do, and they put us 1, 2, 3. So we're not going to go to all these, because when we looked at this mutation, you find many of them, some of them significant, some of them not significant, and there's difference really in their prognostic factors. So I think it is important for us in our part of the world to listen, to put on a list all these markers, and when we look around, we find actually medicine that they can do them. At King Fahd Research Center, I think if you can provide us with what you need, I can tell you really, we are ready to do all these, or most of these markers, as easily we can do it for you. And really, I'm looking forward for standardizing management, because we have a lot of problems in using different regimens, actually not in different institutes. We'll find it in the same hospital. We are also using different regimens. Thank you very much.
I'm Dr. Aslam, hematologist in King Faisal Hospital. Just for Dr. Damanpuri's comment, we are in the process at King Faisal to standardize the guidelines, and we hope that we are invited comments from several institutions. So we are trying to come up with a common guideline which may help to standardize. And I think one of the steps as Saudi group of hematologists that you might need to consider is to have some kind of collaboration between different institutions where the real tertiary care goes to real tertiary care, and then, consolidations of those kinds of things can be done to other places. But my question to Dr. Kelta, would like to comment on the newer emerging antibody therapies for multiple myeloma.
If you look at the presentation given last ASH meeting, 2012, there was some abstract, and again, to be honest with you, I'm not the most familiar with those protocols, but I can see the trend. When this monoclonal antibody comes for myeloma, I try to link myeloma. Probably they are somehow a spectrum of the same disease, myeloma and lymphoma. They started with chemotherapy, and monoclonal chemotherapy was added for elderly first, and then for younger population. And I think the same trend will apply for myeloma. So I would not be surprised if monoclonal antibody for myeloma is added to the current regimen to give you better overall survival, but still very investigation and to come.
You are right, the emerging data on this is really very impressive. And I think the time is coming very soon,
right,
where following the rituximab example, in myeloma we might have a model like that.
because the recent data on this subject is extremely impressive.
So we will end up having something like R-CHOP for lymphoma, we'll have some maybe R-VAD or R-TAD or something like this.
If you allow me just again to ask you probably one of the administrative questions. You know, we face a lot of non-Saudis whom are candidates for bone transplant or stem cell support and they don't have insurance. I hope that you consider these in your guidelines, what to do with these patients and these people whom we face them a lot in the region of the Mecca region. So what's your reply and what's your recommendations for them? What to do? What's your advice?
Can I answer this?
The question is sent to all of you.
Yeah, all of us.
Yes.
No, from you know, Prof. here in the university we started transplant. It's not Saudi, but King Faisal we had also patient diagnosed in the university with medical report if they get royal order, and I can tell you royal order is not something impossible. Our king, our government, they are really helpful, they are really very kind, and they support. We did transplant in King Faisal, many, I don't say a lot, but there are many patients who were referred and they got transplanted. Some of your patients, some of my patients, and all other institutions. I mean, but we need the royal order. For the university now, the new regulation, they are asking for the governor to give an order, and this is something we'll follow. But we are, as I said, compassion is the rule of medicine. I don't know what's the situation in Dammam.
So it's pretty much the same. The only caveat to this is actually a clinical trial will open a channel for people who are not eligible to be treated to be eligible to be treated. So for example, we have the CML trials. There are patients who are actually non-Saudis who fits the criteria for the trial. Most of the pharmaceutical company will actually sponsor their treatment. This could be applicable to other diseases as well, but if we enrich the environment and community with clinical trial, we'll have more entry point for them.
I think for National Guard, they have what's your responsible? You have business center.
Yeah, so we don't have the bomber, we haven't started yet, but I think what Prof. Shaheen is mentioning is about treating in Saudi, which I think is very important in oncology practice. We have a lot of, maybe I would say, politics among all the hospitals and eligibility issues for all the Saudis. So I think it should be done on a higher administrative decisions is what to do exactly with those patients. Even if they are not for transplant, even they just come with a simple early stages Hodgkin lymphoma, they have to pay from their pockets to go to the private hospitals, and some people, most of the patients, they don't have insurance. So I think this is a very important point to take into consideration when making any guidelines, what to do with those patients, how you're going to triage those patients, which hospital is going to accept them. I think that the answer would be difficult at our level, but that's something should be addressed.
For King Faisal, the candidacy for bone marrow transplantation, probably Dr. Aslam is here and he can talk about this administrative issue of non-Saudi undergoing bone marrow transplantation. As
Basim mentioned, we have this channel because for autologous transplant, allogeneic is more difficult. But for autologous transplant, we have many patients in King Faisal Hospital in several departments, not only oncology, who are able to obtain the royal order for treatment. And once they have the order for treatment in the hospital, they are eligible for everything except allogeneic transplant. If it's a matter of allogeneic transplant, they need a separate special order specifying that these are the candidates for allogeneic transplant. So there is a way. It is not so easy, but there is a way, and people have been able to get the orders.
Well, this will close this section, and thank you very much for a nice discussion. Thanks.